How's your gym going, Wilson?
It's going good.
Good.
It's been raining, so we just been limiting the workouts, but benefits for me. I get a workout no matter what.
Yeah, very true.
So people are coming into the webinar, folks.
Okay.
All right.
Wilson, can you close your video till we get going?
Oh yeah, absolutely. Sorry.
Thank you.
Mm-hmm.
But don't go away.
Yeah, I won't.
Patty, I just realized I don't see Troy's on.
I'll text him.
In the event that Troy is not able to attend, do any of the panelists have experience with nocturnal dialysis? Okay, I will finesse that.
And then the home dialysis, the home nocturnal, and the patient partner, I don't see them on the list either.
No, they're
Yeah.
not here yet.
Doris has reached out to them.
Great, thanks. Could you remind me what their names are?
Anthony and Alba.
Thank you.
Hello, everyone. We'll be starting in just a couple of minutes. We're letting people gather. We're going to get started in just a couple of minutes. Thank you so much for waiting. Thanks to all of you who are putting where you're from in the chat. Make sure you send it to everyone. We'd love to know where you're tuning in from. Eugene, Oregon, Michigan, Marin County, Chicago, Las Vegas. Got all kinds of weather represented here. Santa Barbara, Woodinville, Greenville, South Carolina. Might get the most FAR award so far. New York City, Portland, Oregon. Ooh, Shelter Island, Alaska. Virginia. Thank you so much for spending the afternoon with us. Redwood City, local. All right, San Francisco. Hi, Jeffrey. Sacramento. Another Santa Barbara. Welcome, welcome. Olympia, Washington. Thank you so much. Oh, we're going to go ahead and get started. All right, good afternoon, everyone. I'm Patty McCormick, the Program Director for the National Kidney Foundation serving Northern California and the Pacific Northwest. Welcome to today's webinar. We're so glad we're able to gather virtually with all of you and share this important information. Today, we'll hear from Dr. Anand of Stanford University. Dr. Anand will provide an update on dialysis patients' antibody response to the COVID-19 vaccine. Following that, we'll have a panel discussion with patient experts who will share the different ways kidney disease has impacted them over time. And for our third and final part of the session, Dr. Osama Amro will moderate a presentation by Dr. Suzanne Watnick on managing some of the more common effects of kidney disease. Some housekeeping. This webinar is being recorded. We will share links to the recording and resources in the follow-up email. We ask that you please complete the evaluation at the close of the webinar, and for extra motivation, you'll be entered to win a $50 gift card. Please give us your feedback. It's important that we know how we did. For today's webinar, all audience members are muted. Please use the chat box to share reactions and comments, but please use the Q&A box for any questions you would like to ask the presenters or panelists. This is very important. The two different icons are on this slide. Again, please find the Q&A icon, usually at the bottom of your screen, and make sure to put any questions there. We encourage you to select everyone versus hosts and panelists when using the chat and Q&A so that you can see each other's questions and comments throughout the session. For any questions we're not able to get to live today, we will answer in our follow-up email. For those of you who attended last month's webinar and are waiting for the Q&A write-up from that, you will receive it in the next couple of days. There were over 100 questions answered by our presenters from that session. Next, I want to share this important acknowledgement. While the participating medical professionals are licensed and qualified to practice medicine, it's essential that you always seek the advice of your physician or medical team with any questions you have regarding your specific personal medical condition. The information shared today is not intended or implied to be a substitute for professional medical advice from your healthcare provider. It's time now for us to recognize our partners who help make this work possible. We're grateful for the support of our presenting sponsor, Horizon Therapeutics. Horizon puts patients first by developing and discovering medicines that address unmet needs. They believe science and compassion must work together to transform lives. And also to presenting sponsor CareDx. The CareDx team is committed to improving transplant patient outcomes by providing innovative and intelligent solutions throughout the entire patient journey. And I am going to stop sharing my screen. And before we dive into our agenda, we are going to hear from one of our wonderful planning committee members, Esther May Jones. Esther May is a transplant recipient and a registered nurse and a longtime NKF volunteer. Today, she is sharing a brief presentation she put together. It is homemade, somewhat goofy, but shares very important basics on antibodies. Take it away, Esther May.
All right. This presentation is to help with vocabulary and concepts in the following talk by Dr. Anand. The main picture shows a variety of bacteria and viruses that can make us sick, called pathogens. If we look closer at the pathogen in the middle, we see an antigen, the part that interacts with our immune system. Some of our immune system can be found in our blood. If we take a sample of our whole blood and spin it around super fast in a circle, like in a carnival ride, the heavier or bigger something is, the farthest from the center it wants to go. Our red blood cells are the biggest cells, so they go to the bottom of the tube, which is farthest from the center in a centrifuge machine. Our plasma contains small proteins, so it can be found on the top. The in-between layer is where the white blood cells reside when separated. There are 5 main categories of white blood cells, 2 of which will be brought up in the upcoming slides. Monocytes, which can mature into macrophages or big eaters, and lymphocytes, which can be broken into 2 groups, B lymphocytes and T lymphocytes, also known as B cells and T cells. In the plasma portion, we see all sorts of proteins, most of which are albumin. The specialized protein we will be looking at is called an immunoglobulin, which is a type of protein used in the immune system to bind with the antigens of pathogens and makes them useless. Another name for this type of immunoglobulin you likely have heard about and will hear further about today is antibody. Because this is flowing freely within our blood among other body fluids and tissues, we can also call this a free antibody. My name for this little guy is Snappy, because my stuffed antibody has a snap that attaches it to the particular antigen for which it is designed. Immunoglobulins can also be found within membranes, the outer surfaces of cells of lymphocytes. Here we see Snappy membrane bound on a B lymphocyte. So in this position, he can be called a membrane bound antibody. However, Snappy is highly unusual because antibodies either live in the membrane or live in your body fluids after their creation, not both. Snappy is a weirdo since he appears to do both. Now we are going to see two general roadmaps of how free antibodies are made. If there is a new pathogen or vaccine, our bodies are limited to this pathway to create antibodies. It looks like my screen kind of went away. I don't understand what's going on. To create antibodies, which takes roughly 2 weeks from beginning to end. The other type of white blood cells I brought up before, macrophages, or big eaters, wander around your body tissues hungry for pathogens the way Cookie Monster is hungry for cookies. Once they eat up pathogens or spike proteins, as in the COVID vaccines, they put a bit of the antigen on their surface and display it for a helper T cell to help a macrophage monster out. Because macrophages present the antigen to the helper T cells, introducing the antigen to our big bad immune system, they are also given the name antigen presenting cells when they are on the job. They unfortunately cannot present the antigen directly to a B lymphocyte. Perhaps B cells are snobs and only like to connect with other lymphocytes. Whatever the reason, helper T cells then take that antigen and connect it to unspecialized B cells, which then start to reproduce what we consider activated B cells, among other types of B cells. Activated B cells can go after the pathogen directly. Memory B cells are created to have longer lifetimes and to continue to survey the blood for future infections from the specific pathogen. And plasma cells, just think of them as antibody factories. They send out swarms of specialized antibodies to this pathogen to neutralize the current infection. Those antibodies glom onto the pathogen, making it impossible for the pathogen to bind in the body and replicate, a pathogen's version of making babies. Some antibodies don't find a pathogen linger and linger for some time before they get to the end of their life. Sadly, this pathway for antibody production takes time. So if the pathogen is particularly deadly, the body may not be able to mount this defense before the body succumbs to the disease. Vaccination is a way to trick our bodies into making the same responses as natural infection without having to worry about getting super sick, if your immune system works well, that is. Sorry for doing this, but does anybody else
Esther,
do
we
you
can
see
see
my
your screen. Esther, we can see your screen just fine.
with the slides?
Yep.
Okay,
Yep,
great.
you're good.
Okay, next one. So after recovering from infection or vaccination, there is this additional pathway that opens up, but please notice that steps 2 to 5 are the same. This whole process may take a day or two, which diminishes symptoms of the disease, perhaps even making it so illness doesn't even happen. How it starts is from the remaining memory B cells wandering around the body and bumping into the known pathogen. We have all sorts of B cells that have been educated. Should they run into the specific antigen, they have been educated to see. You can think of memory B cells as part of an antibody menu, like in a restaurant with pictures and numbers. Let's call this memory B cell number 23. Once a number 23 memory B cell is ordered or chosen from the millions of menu options, that memory B cell asks a helper T cell to help initiate the production of the various specialized B cells, including number 23 plasma cells, which then produce mass amounts of number 23 antibodies to neutralize the number 23 pathogen. When the immune system is all functional, it's quickly game over for pathogen number 23.
Thank you so much, Esther May. Before I introduce our next speaker, I'm going to launch a poll. just to see who's out there. So go ahead and take a little bit to answer that question. It's on your screen. Esther May, that was an excellent primer on antibodies. We got a comment in the comment box saying that you deserve a reward for making complex info accessible and fun. So thank you so much, Esther. And I think we're almost there, 80%, 82%. And I'm going to end the poll in 3, 2, 1. Looks like we have lots of folks in both the kidney disease, but not on dialysis, transplant recipients, friends and family. There's the results. Excellent. And so that leads us into our next speaker. It's my pleasure to introduce Dr. Suchi Anand. Dr. Anand is engaged in clinical research aimed at advancing the care of patients with kidney disease living in low resource settings using practical tools. She has active projects in collaboration with US universities, CDC, and internationally in India and Sri Lanka. Dr. Anand received her medical degree from Washington University School of Medicine in St. Louis and completed her internal medicine training at Brigham and Young Hospital in Boston. She completed her master's in clinical epidemiology and nephrology fellowship at Stanford University. We're very grateful to have you here today, Dr. Anand. Take it away.
Thank you so much for having me, Patty. And I'm really excited to talk to all the audience here, but also thank you, Esther May, for that wonderful primer. It really gives me a good launching pad, so thank you. I share my screen, but Patty, actually, should we run our polls first?
Yeah. Okay.
So I have a few questions for the attendees as well. As we talk about vaccine response, I wanted to first understand what is the lay of the land in terms of how many people are already vaxxed, how many people have chosen to get boosters already, and how many are still considering. And no judgment here.
Okay, we're at 64%, 65% answered. Give a few more seconds. If we can get it up higher than 90. Almost there.
I will share that I am vaxxed, but not yet boosted. Yeah, okay, there's the majority are boosted. That's great. And almost no one who hasn't. So we're talking to an audience that is mostly vaccinated. That's great news. Another question that I had was which type of vaccine?
A few more seconds.
I will share some data that we have for patients on dialysis by vaccines. Okay, so this is the spread of most of the US. Most people have either Moderna or Pfizer, and a small minority have the Johnson & Johnson vaccine. Good to see those too. And I think I had a last question about, what was or is your most pressing concern about vaccines, specifically about COVID-19 vaccines, but if you have concerns about others, that's great too. So my personal concern is always the immediate side effect. And I know there might be other concerns. Sorry, I had to limit the poll to 3 options, or I chose to limit the poll to 3 options, but there might be other concerns that people can ask me about later. But these are the ones that are informed by our research that patients tended to have. Okay, they won't work to protect me. Okay, well, yeah, since we're talking to a vaccinated audience, they've been through the immediate effects. Some people are concerned about the long-term effects, but the main concern seems to be whether it will work to protect you. I think now just as a caveat here, this is a talk focused on patients on dialysis. I know many in the audience are people with transplants, and I will refer you to the prior webinar that the Hopkins team had about your concerns about protection. But here I'm going to focus on patients on dialysis. So we have a big team working on this question, and it's a team that is made up of academic folks like myself, statisticians and infectious disease experts and immunologists. But also we have great partnership with Ascend Clinical Laboratory, which is a commercial laboratory that runs about the monthly labs of about 60,000 patients on dialysis every month. And then we have two dialysis networks that we're partnering with. One is US Renal Care, who are represented by Dr. Blocks and Dr. Dittrich. And then the second is Satellite Healthcare, our Northern California not-for-profit dialysis network. And so we are really grateful to be working with all of these folks. It's been a great, productive, and very fruitful partnership. And most of the data I'm going to present are from this partnership, but I have read all that's out there. So again, if people have questions, I'm happy to answer them later. I don't have disclosures. So we went through these. Okay, so my talk is in three sort of sections. The first is we're going to talk a little bit about vaccine acceptability among patients on dialysis. Then we'll talk about why should we worry about the vaccine response in patients on dialysis, and then we'll end with the data that currently exist on vaccine response, SARS-CoV-2 vaccine response. So vaccine acceptability, this is not the audience that is represented in this graph, but even at the end of December, when December 2020, if you think back to that time, that really anxious time in our lives, we had good news that there was going to be a vaccine that is like at least one vaccine that's likely to be very highly effective. And that was either the Moderna or the Pfizer. And in serial questions to the US public about their acceptability of an effective vaccine, knowing that one effective vaccine exists, people were expressing high degree of reluctance to get vaccinated. Here you can see that about less than 60% of the US public, even in the first week of December, after they knew about these effective vaccines, were not interested in getting vaccine, or they were thinking that they probably wouldn't get the vaccine. And that really has borne out in our real life data. These are the up-to-date data from this year. Looking at how, in the blues are the people who completed vaccination. So you can see that's about 50% or 55% of our US public has completed vaccination. And this is among adults, and then more than 60% now have a single dose, but not of the mRNA vaccines haven't completed the vaccine yet. So, it was, about half of the US public said they weren't interested in the vaccination, again, discussing adults, and about half weren't vaccinated as of this summer. Now we're making some slow progress, but it's been slow and wrenching. And so we were concerned about this as a potential concern of patients on dialysis as well. And we were concerned about vaccine acceptance. So in January of this year, in 2021, when vaccines were starting to come out and be rolled out to our patient population, we sent out a questionnaire to see how many people, like to discuss whether people were vaccinated or would want to be vaccinated against COVID-19 or not. We wanted to specifically focus in on our population on dialysis, and we could build programming around that, their requirements and their questions and their concerns. And so we partnered with US Renal Care and provided a quick online survey that was able to be launched. benefit of the telehealth provision in dialysis facilities has been the ability to have electronic sort of medical record, but also electronic interfaces with physicians. And so we were able to use the facility iPads or the smartphones that the patients already had to ask them to do this quick 15-minute survey. And we got representation from throughout the US, including Alaska. The people responded to the survey, about 1,500 people in, within 2 weeks. Most of them were pretty much representative of the US dialysis population as a whole. So you can see, we even got some people who were over 80 years of age to answer this online survey. And we were throughout the US, as you saw in that map. And we got people who were Spanish speaking as well to respond, just to try to get an opinion from everyone and understand their concerns. And what was really heartening to see, so now here, the blues in this graph are people who are thinking they will likely get vaccinated as of January 2021. And the reds are people who are hesitant, would not necessarily pursue vaccination quite yet, would want to have more information. So unlike the US public at the time, only 20% of our population expressed hesitancy. And about 30% of younger people expressed hesitancy. People who self-identified as Black were more considering whether they would get vaccinated or not. And similarly, people who fell in the other racial category, so that was mostly Native Americans and Pacific Islanders, felt that they wanted to learn more about the vaccine or probably wouldn't get vaccinated. And interestingly, we asked if the provision of the vaccine in the dialysis facility would improve uptake, and it didn't necessarily seem to, although obviously it's practically much easier to get vaccination if you're on in-center dialysis or are visiting the dialysis facility more frequently. The major concern was the side effects, although some people felt like a majority of this group that the vaccine would not work to protect them. And then some people just felt that the vaccines in general are things that they don't want to pursue, and they don't want vaccines in general. But in general, our results matched what the general population had expressed. Most patients had expressed, most patients who expressed higher hesitancy or higher degree of uncertainty about vaccines were women, people who self-identified as Black, younger people, people with lower, less than a college degree, and people with lower income. We also found that Native American and Pacific Islander patients had concerns about vaccines. But overall, in general, like as I showed you, about half of the US population had concerns about vaccines in November and December, and in January, about 80% of our patients said they would take the vaccine. So that was encouraging. But we've also since done a follow-up in partnership with Satellite Healthcare to see who has and hasn't gotten vaccinated, and it's clear we haven't reached everyone. And again, this is focusing on patients on dialysis. This was a survey through Satellite Healthcare. So they're a smaller not-for-profit organization that is mostly in California, some locations in Tennessee and Texas as well. And again, in this, the reds are the people who are thinking about or have not gotten the vaccine as of June 2021. You can see that, again, younger people were more likely to not have gotten the vaccine as of June 2021. People who were self-identified as Black or had racial categorization as other, which I know our electronic health record isn't great as capturing race and ethnicity, they were more likely to have not gotten vaccinated. But what we had missed in our original work and what is clear now is that it's also a matter of where you live and what your community norms are, because most of California's dialysis population had chosen to get vaccinated, versus in Tennessee, only about half the population had gotten completed vaccination as of June 2021. So I think the main takeaway that I have from this is that, like I said, more of our patient population is willing to accept vaccines. And that might be because of the trust that's built by being in a medical home, which is a dialysis facility, whether that's in-center dialysis or via peritoneal dialysis or home dialysis. You do feel like you belong to, or I hope patients feel like they belong to a network or a group of people who are there to support them. And that's how we deliver a lot of other vaccines, including hepatitis B and influenza. And so there is a tradition of offering vaccines to patients on dialysis that is established. So it's not like a new phenomenon. And so and also, I know that some of my patients are acutely aware of their risk. If they do get COVID-19, they know that they could get seriously ill. And so for them, that could be another motivating factor to get vaccines. Although we have more of our population vaccinated compared to the US general public, there still remains, though, a group of people, mostly in the US South, who have not gotten vaccinated. And that's a substantial group, substantial minority that still remains at risk. Okay, so now shifting over to studying vaccine response. So the first question is, why do we need to study vaccine response in patients on dialysis separate from the general population response? And the reason for that is knowledge that we've gathered from hepatitis B. And so this is the hepatitis B virus. It looks different from the SARS-CoV-2 virus, which you may have seen pictures of, but it is a bloodborne pathogen. And in the 1980s, 1990s, when vaccination started to become available for hepatitis B, there still remained concern that there were outbreaks of hepatitis B infection among patients on dialysis. And so the CDC really drilled down and tried to figure out why were these outbreaks happening and what are some things that they could do to prevent them. And part of the reason for these outbreaks, it was clear, was that patients on hemodialysis tended to have a lower vaccine efficacy. So again, these data are small, but what gotten from small studies, but what they generally show is that in the general US public, and I guess I just mean in the general healthy population not on dialysis or not with kidney disease, only 5% of people who completed a series of hepatitis B vaccine would have no response. So, if I was vaccinated for hepatitis B, I got my 3 shots, and then a month later or 2 months later, someone measured my antibody levels. There was a 95% chance that I would have antibody levels available. In patients on dialysis, however, the efficacy is lower. In the current vaccine schedule, about 73% of people will have a response. If I'm on dialysis, the likelihood is 73% that I would have a response. And then there's a substantial likelihood that I would have no response 2 months after I've been given 3 doses of the hepatitis B vaccine. And this is based on small data, but there were multiple small studies confirming this. And in influenza vaccines also, influenza vaccines in general have lower efficacy in the US public or in the general public, but in patients on dialysis, the response as measured by antibody titers is lower. And there's a higher likelihood that there will be no response. There's an even higher likelihood that there will be no response in transplant recipients. So this is 43% no response, and in transplant recipients, it's close to 50 to 55% no response. But there's a large portion of patients on hemodialysis who would not have a response post-influenza vaccine. And so on this basis, if you go to our medical textbooks and our medical guidelines, there is a separate category for patients on dialysis. And what's two of the things that are emphasized there? One is that for hepatitis B, which can really easily be transmitted because it's a blood-borne infection via dialysis, that we first check. So if someone is not vaccinated, we first vaccinate them. And then we check 2 months post-vaccines what their response to the antibody, what the response to the vaccine was. And if there isn't a response, that we revaccinate. Also, and some of the patients on dialysis will know this, that they would have gotten yearly hepatitis B surface antibody titers checked. And then if they don't have a measurable response, they would get a booster. Or a measurable response meeting that 10 unit per ml threshold. And then patients on dialysis are offered the high dose influenza vaccine regardless of their age. The reasons for why patients on dialysis don't have a good response are incompletely understood. There are data showing that, if you have kidney disease, but you're not yet on dialysis, that you're more likely to have a better response. So I encourage my patients to get vaccinated. If they're nearing starting of dialysis, I encourage them to get vaccinated before they need to get dialysis. So for their pneumovax, for their Zostavax, anything, I try to get them to get vaccinated earlier. The concern is that there is something going on when patients have end-stage kidney disease, where there is an influx of uremic toxins that prevent the immune system from working well. And it's not necessarily the other conditions that sometimes our patients can have, like diabetes or high blood pressure. It's the kidney disease itself. Okay, so now, given that context and given the context that Esther May gave you, let's talk about SARS-CoV-2 vaccine response in patients on dialysis. So this is, some of you may have seen this in images from the media, but this is what the SARS-CoV-2 virus looks like. And it has a number of the antigens that our antibodies can snap into. And referring back to Esther May's talk. But there's only one major area of antigens where the responses are likely to block the virus from actually entering our cells. And that area is the spike protein, which is what the virus uses to get into our lung cells. And so antibodies that are directed against the spike protein generally can have neutralizing effect, meaning that they can block the virus from entering. There are other, as Esther May mentioned, there are other ways that our immune system responds to an infection, and these include the T cells, but also memory B cells that are generated later on after exposure to a specific antigen. But we're going to focus here on the spike protein and the antibody response to the spike protein. And in fact, we're going to focus more on the receptor binding domain of the spike protein. So how the spike protein actually binds to our lung cells. Like, it has to basically open up a hinge region and then get inside a receptor. And so the antibodies that are specifically targeted to this, you can imagine, would have a likelihood of potentially having neutralizing effect if they block this receptor binding domain from actually binding to the receptor and getting into the cells. So we're going to focus here on receptor binding domain. So this is a study that we did with US Renal Care, and we didn't look at US public data, but based on what the vaccine manufacturers had published in their phase 3 studies, we know in general in the US public, 100% of people who are vaccinated will have an RBD antibody response. These were good, effective vaccine. There was a response in a vast majority of people. In patients on dialysis, so the blue here indicates people who didn't have any measurable response. So about 8% did not have any measurable response. And the gray here is that 14% number is people who we think had suboptimal response. Now, this was work that we were doing before we knew as much about the particular assay we were using and how well it really correlates with immunity. and risk for infection. But this is what the assay manufacturer told us. Well, if it's below this level in the response is below this level, then it's likely suboptimal. And so, we definitely were comfortable saying that about 8% of patients in dialysis did not mount a response. And then there was a possibility that an additional 14% would have suboptimal responses. This is, if you're familiar with the data from the Hopkins team, this is very different. Sorry, I sent out a slide share because I couldn't see this number, but just wanted to point out this 46%, which is the 46% is the number to compare to against 8%. So 46% of the people on with kidney transplants did not have a response to the initial schedule of mRNA vaccines. So there is a large difference. There's patients in dialysis more likely have a response compared to patients with kidney transplant, although there's still a small minority that is likely unprotected after the initial series. We also looked at the vaccine response by antibody type. And again, the blue is people who didn't have any response. The gray is people who had some response, but perhaps it was suboptimal. Among the two mRNA vaccines, there was a slightly higher response in the people who got Moderna in terms of the rate of seroconversion. And also we saw the mean antibody titers being higher in people who got Moderna. And we saw, somewhat lower response to the single shot of the J&J. There are data coming out from the general public also supporting these findings. And there are others, the other group that's working on this information is from DCI, another dialysis network, and they also see this effect of a lower efficacy of J&J in our population. Other factors that influence response. So if you were younger or had longer vintage or longer number of years on dialysis or lower serum albumin. Now, serum albumin is a measure that we use to help us understand how healthy someone is. So if there was lower serum albumin, then people were less likely to have mounted a response. This is another group that looked at this early on, and this was a small study, but they had healthy workers as controlled, healthcare workers as their controls. And you can see the quantity of the response is also lower in people on dialysis. And these are the total antibody titers. So 10,000 on average for healthcare workers and 4,000 on average for patients on hemodialysis. So now the question about boosting or not boosting. So basically what I've told you is that there is a slightly lower response, better than in kidney transplant, but worse than in the US general public for patients on hemodialysis to the vaccines. There is there would be some concern about people who've gotten the J&J, and that the overall quantity of the response is likely lower than in the general population as well. Now the question is, should patients on hemodialysis get the booster? I mean, most of us are pursuing boosters, but just to show you the data for the rationale for this. So this is our data showing the same assay measured over time since vaccination. And this on the y-axis are days since vaccination. And so you can see this is the 5 to 6 month window post-vaccination. And the line to focus on here has the circles. And you can see that the circles show that the circulating antibody titer is declining fairly fast in our patients. And the decline was occurring even in people who had had prior SARS-CoV-2 infection. So even they have a loss of circulating antibody titers. And then same for regardless of which vaccine people have gotten, whether it's J&J, which is this one, or Pfizer or Moderna, people are having a decline in their circulating antibody titers. Now, this is not unexpected. We all will have a decline in our circulating antibody titer. That is how the immune system works. But the question is, does having a very low circulating antibody titer or an undetectable circulating antibody titer mean that a patient could be at risk for breakthrough infection? And we have started to study that question. So we looked at antibody response after full vaccination, either the peak antibody response or the pre-infection, meaning the pre-breakthrough infection response. We measured it using just a very simple commercially available assay, and we're looking again only at the circulating antibodies here, and did find that the risk for breakthrough infection was higher among people with lower antibodies, either at the peak of their response or at right before the infection. So we only had about 50 people in our study who had breakthrough infection, which is a small number, but this is, you have to time the antibody response levels and have data on infection as well. But majority of these people, of these 50 people or so that had breakthrough infection were hospitalized. So they had they had a consequential COVID-19 diagnosis is how I would put it. For them, there was a risk that was associated with their circulating antibody titers. And something similar is also being shown by the group from DCI, where they're finding a risk when people who have very low to no response on the in terms of circulating antibodies post-vaccination, increasing the risk for breakthrough infection. So, whether this will hold true, whether our antibodies will decline this much, or whether there will be somewhat of a remnant antibody response among people who have a third dose, we don't know. This is still data from people who've only completed 2 doses or a single dose of the J&J. So I'm going to wrap up here. So we can have more time for the other panelists, but I just wanted the main message here is that patients on dialysis should get vaccinated. More likely than not, they will have a response to the vaccine. We should also get boosted because it's not clear whether the vaccine should have been 3 vaccine series as well already. And this rapid decline that we see in the circulating antibody titer will stabilize off if we all get boosted. And then we and others and other people are very aware of the risk in patients on dialysis and are working hard to see if there are additional steps like for hepatitis B or like for influenza that can help tune the protection, that can help increase the protection for patients on dialysis. So I will end here. I just wanted to acknowledge the big team of people who have helped generate data, analyze data, and present it rapidly to everyone so that it can really inform policy. Thank you very much for your time.
Thank you, Dr. Anand. There's one quick question. I think it'll be quick for you to answer. If someone had the J&J vaccine, would it be better to switch to the mRNA vaccine to boost?
So that's a fantastic question. I have not personally seen the data for what happens if we get a J&J second shot and how long it lasts. Now those data will take a little while to come out, I'm sure, because we're just going to be getting the J&J boosters. But we do know that at the beginning, the mRNA vaccines do provide a bigger response. So it may not be a bad idea to have an mRNA booster.
And one more, which looks very important. How can I influence my friends and family to get vaccinated?
That's a tough one. I think, there has to be no judgment first. I think that's the bottom line. People are concerned and they're concerned for legitimate reasons, hopefully. And so we just have to listen with that perspective. There's a lot of research into prior to the SARS-CoV-2 epidemic about how we get people to increase their uptake of vaccines. And as physicians, it doesn't work if we say, oh, you're endangering public health if you don't get vaccinated, or, oh, this is, we all need to reach herd immunity here. And the thing that works is trying to get the specific concerns of our patients, try to understand them, and then answer them specifically to their situation. Here's another one who's going to get a shot as soon as it's
You have
available.
a friend. Yes, you have a friend. Well,
I have
thank
a
you
friend
so
who's
much.
not yet vaxxed, but she
Oh.
will be soon.
Hi. Thank you so much for your time, Dr. Anand. And,
Yeah, no, thank you
it's
so much for
grateful.
having me. And I look forward to any other questions I can answer. Thank you guys.
We'll
for your
forward
time.
those to you. Thank you so much. Okay. Up next is our patient panel. Moderating the panel is Glenda Roberts. Glenda is a transplant recipient and the Director of External Relations and Patient Engagement for the Kidney Research Institute and Center for Dialysis Innovation at the University of Washington School of Medicine Nephrology Department. Our team has been thrilled to partner with Glenda as a member of the planning committee and a past panelist herself. I'll let you take it from here, Glenda. And panelists, please come on camera.
Thank you, Patty. Yes, all of my panelists, please join us. I'd like to say to everyone who's joined us today to thank you very much. We have a great panel of people that are joining us. They have lots of experience walking this journey with kidney disease, and they're going to share some of their perspectives. I'm going to give them an opportunity to introduce themselves, and I'll call you out to make sure that I cover everyone that I see on screen. And we will then give them an opportunity to share some of their story before we ask some specific questions. So Doris, you're at the top of my screen. We'll start with you.
Okay, my name is Doris Liu, and I am a transplant patient, transplanted 5 years, and I was diagnosed with IgA nephropathy, and I went through 1 year of peritoneal dialysis.
Thank you, Doris. Wilson.
Oh, thanks, Glenda. Hi, my name is Wilson Dew, aka the Renal Warrior. I am a dialysis patient, been on dialysis for 5 years in clinic hemodialysis. My original diagnosis was from untreated high blood pressure. So,
Thank you very much, Wilson. So next we'll go to Troyce.
Hi, folks. I'm from Portland, Oregon. My name is Troyce Crucchiola. I have been dealing with renal disease for 33 years. I've had 2 transplants, 7 years of PD, lots of home dialysis as well, and I am now nocturnal in center.
Thank you, Troyce. Julie.
Hi, my name is Julie Hogan. I have received a transplant and my original diagnosis was polycystic kidney disease. My transplant was about 20 months ago.
Congratulations, Julie. And Anthony and Alba.
Hi.
Hello. Hi, my name is Alba. This is my second time being on dialysis. The first time I was on dialysis for 6 years. I got a kidney transplant in 2016. Unfortunately, that failed, so I'm back on dialysis. I did center for a couple months, but now we are doing nocturnal on-home hemodialysis.
Great.
And yes, hi. Yeah, and then I'm her caregiver, helping her with the nocturnal dialysis here at home.
Thank you. I think I got everyone, right? I want to make sure I didn't leave anyone out. Okay, so why don't we start by giving you guys an opportunity to briefly tell your story. You know, we have 40 minutes roughly, so I'd like for everyone to share your story and then we'll ask a few questions. So this time, let's start with Wilson.
Yes, thank you, Glenda. Again, Wilson Dew here. Yeah, it's been about 5 years. It's been one incredible journey, I tell you that. I started into dialysis, or my journey started about 5 years ago, June of 2016. Did not know I had kidney disease, and through a gout flare-up, had to go to the ER. And upon going to the ER, that's when I first found out I had stage 5 end-stage renal disease. At the time, I was working. I was just so hyper-focused on work that I did not take care of my health. At the time of diagnosis, I was roughly about 315 pounds. Blood pressure was through the roof, and was really, really sick when I found out I had stage 5 end-stage renal disease. A few months later, I crashed into dialysis. I was in denial, didn't want to believe I had to change my lifestyle, didn't really believe that my life was going to change until it did. Went into the ER again, started dialysis, had a catheter through a chest catheter, and I was hospitalized that time 6 to 7 weeks. And at that moment in time was a very, very dark time in my life. Life turned upside down. I couldn't move. They said I didn't qualify for a kidney transplant because I was too overweight, that I probably wouldn't even survive even if I had a candidate. So I really was depressed and just fully dependent on folks like my parents and my family to survive. But, you know, I had an epiphany one day and said, you know what, if this thing's going to kill me, I'm going to choose to fight. And that's when I just kind of clawed my way, took literally blood, sweat, and tears, crawled when I couldn't walk, walked when I couldn't run, and just started running and just started training myself day after day, and just fought through it inch by inch by inch. And, you know, the mind and the body is an incredible thing. Even though we're going through dialysis, even though we're going facing a lot of difficult things, doesn't mean you have to go fast, doesn't mean you have to be strong, but as long as you keep moving towards your goal, you'll be able to get there. And so it's been 5 years. I took a few steps off the wheelchair when I first started. I never looked back. And I will tell you, as of today, I've lost about 130, 140 pounds. I train like an athlete. As a matter of fact, not only do I train myself like an athlete, I train 3 or 4 times a week. I do strength training. I do boxing. I biked up and down the coast of California while on dialysis. And not only that, I train so many people. I train. I opened up a gym here in my hometown in Alameda. I train other patients so that they can live their best lives, as well as I train people in the community. I train them in boxing, strength training, all this stuff. And I learned all of this stuff while on dialysis. So, you know, for those of you that are out there that are on dialysis right now, enjoy the journey, keep moving towards getting better. And that's pretty much my message, but that's my story in a nutshell.
That's powerful and very inspiring. Well, we have a lot of other people with a lot of other inspiring stories, not like yours, but in a different way. So I'm going to go to Doris first so she can tell us about her experience. And keep in mind that while Doris is a transplant recipient now, she's also had experience with peritoneal dialysis. So her perspective will be very interesting. Doris?
Thank you. And thank you, Wilson. I've heard your story a bunch of times, so I never tire of hearing that. So thank you for the motivation. So I was diagnosed about 7-8 years ago, and actually not by a medical provider, in that I found out that I had kidney disease when I applied for and was denied life insurance. And, you know, they sent the nurse out, you know, took my, well, they didn't take my blood, but the EKG, blood pressure, the whole bit. And that's how they found that. Well, and then they denied me. And when I asked why, they said there's too much urine in, too much protein in your urine. And so I had no clue what that meant. Went to the doctor and he said, well, it just means there's something up with your kidneys. He never used the word disease, but he says, we're going to change your blood pressure medication. Because I did have high blood pressure, even though I didn't really fit the profile. I learned later on that it was because of my kidney disease, that because we know healthy kidneys keep blood pressure healthy and keep your bones strong. I had both osteopenia and high blood pressure, and back then I didn't know why. But from there, he said, we'll switch your medication. That did not fix my kidney issues. And so from there was referred to a nephrologist who at first also didn't seem that concerned, because, you know, those of you with kidney disease later stages, some of you might have swollen ankles from all that fluid retention. I didn't really have that, but again, he sent me to get the ultrasound, and so they found that, he said, there's lots of cysts on your kidneys, and so you have something called polycystic kidney disease. And so I didn't know anything about, I didn't know anybody with kidney disease. I had found National Kidney Foundation, got online, researched everything I could, and realized that kidney disease actually affects a ton of people. 1 in 3 are at risk, 1 in 7 have it, but the vast 90% of people who have it don't know that they have it. And so I realized I was among those people who just had it for a couple of years, because I went back and looked at some of my earlier labs. I had kidney disease. I just didn't know. So from there, my kidney function continued to decline. I had read that when my kidney function, GFR, drops to 20 or lower, you can get a referral to get a transplant. And so when I went to my nephrologist, I said, can I please now have, my GFR is now 19, please send me to a transplant center. And he said, why? You're still young, you're feeling good. Why get surgery now? And so that kind of started my whole, deeper into research that was not consistent with anything I had been reading. I knew that the wait list was long. Back then, I think it was like a good 7-8 years long to get a transplant. And so I started to research more, found out about how to find a living donor, put out letters, social media, messages on my church bulletin, all of that. So eventually I did get a living donor. We went through about 7 or 8 living donors. So I realized that I am crazy lucky that I can say that a bunch of people came forward to get tested. I think where it was really hard for me, and I think for a lot of people, is just the unknown. You have no idea what is your future going to look like. In the meantime, you're going through dialysis, you're experiencing some of the cramps, you're experiencing nausea, I'm not able to eat, I have to take in more protein because dialysis is getting rid of a lot of your protein. So, there are just a lot of the side effects, but I think for me, mentally, it was really tough, just the unknown. When am I going to get and just watching your donors fall through. There was one even where we had set the transplant date, and at the last minute that didn't work out. And so, I joined the kidney walk, I joined the kidney community, and so I got a lot of support that way, and just connecting with people was really important, connecting with other patients. So I think it's good that, people are here to do that as well. So anyway, I am now transplanted. I'm doing very well. Immunosuppressed and have a couple of issues with that, but on the whole, doing really well.
Before we transition, Doris, tell us a little bit about your experience on peritoneal dialysis. What was that like before you got your transplant?
So peritoneal, those of you who don't know, it's, you have a catheter that's put into your abdominal area, what's called the peritoneum. Dialysis fluid goes in there, and it's doable. It's something I chose to do, that modality, because it's something you do every day. And so I would hear stories about, in-center hemodialysis, where after a session you have this huge drop in blood pressure and you go home and you're completely exhausted. I think for me, I never had those huge drops and huge lows. I was tired often, but not more so after a session. I did experience some cramping. I think because the tube, the catheter, is like a little vacuum. At first the dialysate, the solution goes out through the tube, and then it sits there for a couple of hours, and then it drains, and so it's almost like a little vacuum machine. So sometimes, it gets a little bit uncomfortable. You're large. Nausea, sometimes little appetite, food tasted metallic, sometimes kind of a brain fog, where you would just go about your day, and then at moments you just cannot concentrate. You're trying to think of something, but you're just like, your brain is just really tired and you can't concentrate. Mm-hmm. So I had some of those. And the last thing is just sometimes my body would itch all over. But that actually went away as the more dialysis I did, because I think it was working at, getting rid of some of the toxins in my body. So there were some side effects, but I would say I felt better after I started dialysis, than before I started dialysis.
Thank you. That was very inspirational. And you really set us up nicely to talk to Julie, because when you talk about your experience with getting a transplant and actually getting on the list, Julie has a lot of experience along those same lines, even though she's never been on dialysis. So why don't we give Julie an opportunity to tell her story? Because it's really inspiring.
Thank you. So I was diagnosed with polycystic kidney disease when I was about 26 years old, and I'm 49 now. I'd never heard of it before, and I worked in healthcare as a speech language pathologist, and I didn't know anything about it. So it was scary. But we did find out that it's a very slow, generally, progressive disease over many years. So for me, I had about 22 years to plan for my kidney transplant, which is a long time. And it seemed like, I figured out early on that that was really the treatment that I preferred for myself. It seemed like as a young person that that would be a good option. So I did things like join support groups, find people online. I started a group here where I live, trying to find others who had PKD because I really wanted to, find a community of people. And I found that one of the most helpful things. I got involved as my kidney function fell more in a group with other patients who've had dialysis, all stages of kidney disease, who'd had transplants. And I learned so much. Like, they were such a helpful group as my function was getting lower and lower, because I was really nervous. I even though I had a lot of knowledge and I spent a lot of time researching and trying to get this all figured out, hearing from other people who'd been through it was really important. I also got involved in a clinical trial for PKD, trying to slow the progression of my disease. But when my function dropped into the 20s, I told my doctor, I really want to get a transplant, and that's what I'm going to be working towards. So I did things like get all my preventive care done, make sure I'd been to the dentist, get my vaccines. So I was very ready. And so when my function hit 19, I called my doctor and said, I looked at the portal, my GFR is 19, please send over the referral today. And so he did, and I called the transplant center and said, did you get the referral? And they said, yep, we have it. We'll call you in about 6 weeks. And I was like, well, can't I start filling out the forms today? And she said, no, we'll call you later. And I said, I can come and get them. And she said, no, we have to go in order. And so all of a sudden I realized that no matter how much planning I had done, I hadn't considered all my options. So I called my insurance and I looked out of state and found other places I was allowed to list. And I did that, and it actually went very well. Meanwhile, back home, I was trying to still get listed where I live, and I went to an educational class, and there were about 50 of us in the class, and they asked us to raise our hands, who was already on dialysis, and 48 out of 50 were already on dialysis. So I realized that in my area, they were not catching anybody before dialysis. Like, pretty much everybody, it was an afterthought. Transplant was not the first option offered. And the only reason I was there is because I was pushing and I was, really advocating for myself. So I eventually did get listed, and I had people testing for me, and it was kind of amazing. Also, like Doris, I was so grateful to all my donors. And the second person was in the middle of testing when I actually received a call for a transplant, which was a big surprise. And it was for 2 kidneys from a baby. It's called a pediatric en bloc transplant. And I eventually did receive that transplant in February of 2020. So just before COVID started. So my recovery has been great, except for that, being immunocompromised, right as you start your transplant, and having a pandemic are 2 things that don't go very well together. But I got involved in the Johns Hopkins research, and, I've been following everything very closely with that. But my main message is that, if you're on dialysis and you've never been assessed for a transplant, you should ask and push and really, advocate for yourself and say, I would like to be assessed. And if someone has told you, you shouldn't be assessed, or you don't need to be assessed, or this really isn't an option for you, I would question that and really, push to at least be assessed, because the transplant center is really the only one who can say to you that you might not be a candidate. And if they do, there may be a barrier that you can modify, something that you can get past, and then still be listed. Like Wilson, he was able to, really change his behavior and make it so that, things were different for him. So it's something really important to remember, that you can be your own advocate and, push your healthcare providers to help you to have that option.
Excellent points. After I talked to you the other day, Julie, I happened to be attending the renal grand rounds at the University of Washington nephrology group. And there was a lady from the University of New Mexico who talked about a program that they have deployed at the University of New Mexico, and they're starting to roll it out to other transplant centers, called Kidney Transplant Fast Track program, and it's designed to address the issue that you have outlined, the fact that it takes so long to get through the transplant process or the transplant evaluation process. They've actually deployed a program that's designed to make that better. So hopefully we'll see other transplant centers around the country consider that. So next, let's go to Alba and Anthony, because they are a great patient care partner pair, and they can offer us a unique perspective on Alba's journey and the impact that it has had on both her and Anthony. So Alba and Anthony, you're up.
Hi again.
Hi.
So like I was saying earlier, this is my second time around on dialysis. The first time I was diagnosed in March of 2010. I did in-center for about 6 years before getting my kidney transplant. After that, my kidney failed and I had to go back to dialysis. I was in-center for a couple months, only a short time. Then that's when I actually heard and found out about nocturnal dialysis. Anthony's the one that actually told me about it and encouraged me to do it, because at first I didn't really want to do it. I didn't want to do the whole home nocturnal. But after starting it, you know, we did have some challenges, but I can honestly tell you that it's much better now. I feel a lot better. I have a lot of flexibility in my schedule, such as my work schedule, spending time with family, and overall, I just feel a lot better. And I wish that I would have known the first time around that there is nocturnal home hemodialysis, because like I said, the first time I wasn't even informed that there was such what's it called, a treatment that I could do at home. Like I said, I feel a lot better. I have a lot of energy. I'm able to do so much more during the day. And of course, Anthony, he's by my side. Has been by my side through this whole process. So he has made it very much more smooth. It helps a lot that he is a dialysis technician and he's got a lot of experience under him. So that's a lot. It's a big blessing that I have. So for anybody that is considering doing nocturnal hemodialysis, I would recommend that they do try it if they do have that opportunity to do it, because it's so much better for us as patients.
Excellent, thank you. A quick question before Anthony speaks. You mentioned that you do nocturnal. How many hours a day or a night do you do that?
6.
6 hours, okay, good. And you're able to maintain a full-time job?
I am, yes. Now that I'm doing the nocturnal, yes, I am. Before I was doing in-center, I would have to leave work early and I would have to be there from 3 to 6? Yeah, 3 times a week. But I wasn't feeling as well as I am now that I'm doing the nocturnal.
Great, thank you. Anthony, what would you like to share from a care partner's perspective?
So Alba covered quite a bit of like a lot of the benefits that she gets with doing the nocturnal home dialysis program. So I thought maybe I might kind of maybe just, I guess, express some of the challenges, I guess, that we also have too, you know, with doing this. You know, there was a big adjustment for us doing this. You know, with travel, you know, traveling, we really haven't gone too far away from home. Actually, I don't even really think we've gone overnight really yet. We haven't experienced yet, although that option is available for us using the next stage machine. We just have to do a little bit better planning. We have to, you know, pack a little bit extra, right? Pack our supplies, and make sure we get the supplies that we don't pack sent over to wherever location we're going to be. So there's a little bit more planning involved. Like I said, we haven't experienced that yet. We haven't dived into it. We used to be more, I guess you could say, in the moment, you know, hey, let's go here, let's go there this weekend. But now it's, you know, we got to be a little bit better with planning. We can't just be so spontaneous. And I'd say some other challenges, we got to keep track of our supplies, expiration dates, medication administration. There's logs, making sure that those don't expire. Everything's got a date, whether it be, you're administering heparin or you're administering your epogen. They all have different times, and you need to make sure that, we stay on top of that. Another thing I would say is making the batch of dialysate for the dialysis machine. So that we make, usually I like to do it on non-dialysis days, which is the day that we're not dialyzing. Sometimes I'm not able to do it. So I have to make sure that I'm home to get it started, because it takes about 6 hours to prepare that dialysis for the machine. So that has to be factored in, get off of work, come home first thing, make that dialysate so that way we could use it by 10 or 11 o'clock, so that way we still have, time to get on, get that 6-hour treatment in, and, and we're all set up. Some other ones also is, I would have to say, the cannulating, the sticking the needles, when we first were talking about doing nocturnal dialysis, she was going to have the access placed in her arm, and we were under the impression she was going to have a fistula placed. And with the fistula, they're able to do what's called a buttonhole technique, where they put the needle in the same place every time, and then access that using dull needles. Well, because we weren't able to do the fistula because her veins were kind of small, the doctor put in the graft. So that one with the graft, we have to use sharp needles every time. And so there is some pressure, on my end that I feel, because I want to do a good job putting the needles in. I want to make sure she doesn't feel pain. I want to make sure we're alternating sites, that we don't do that. I think they call it the one-site-itis, where they're putting in the same spot. So I do feel that pressure, come the end of the night, where it's like, I want to make sure I do a good job. I don't want to infiltrate her needles, and make sure that, it runs well at night too. The machine doesn't alarm. So, yeah, definitely pressure I'd say with doing that. And then with doing treatment at night, we used to feel tired at the end of the night, we'll go to bed. But now that's where we have to start getting ready for treatment, so you got to factor a good hour and a half. You take your showers at night, one of us starts setting up the machine, the other one gets out while the other one starts prepping all of the supplies. So it is time consuming. It does take time to plan it out, to complete these treatments. But I'll tell you, I wouldn't have it any other way, because I see the results, and I see how well she's doing with this versus the in-center. In-center, she would come home from in-center and wiped out, want to crash, dinner, it was a lot of it fell on me, and I'm not the greatest cook in the world. But
I can relate to that.
I'll be honest, but yeah, during that time frame we were doing the in-center, she didn't have a lot of energy. We didn't go out on the weekends. We didn't go anywhere.
I had no energy.
That raises an interesting question. When you say you didn't go out on the weekends and you didn't go anywhere, how many days a week were you doing nocturnal home dialysis? Because I heard you say we prepare the solution for the next day. So how many days each week do you actually get the treatment, Alba?
4.
4? Okay.
Yeah.
And you still feel great. That's really encouraging.
Much better. I do.
Excellent.
So yeah, and so we've been given the okay to do an extended treatment, because with a 6-hour treatment, there is like the heparin does stop administering about like an hour before treatment. So there's an alarm for that. So we go and we turn that off, and then, she runs about another hour before she comes off. So really that's 5 hours. So if we went to bed right after she got on, we're looking at, we're looking at like 5 hours of sleep if it's up to that heparin pump. but normally we're up for about an hour. So you're looking at like maybe 4 hours of sleep. So, and that affects your day. It does affect your day, you know, and especially like if, you know, let's say it wasn't a great stick and the machine's alarming. Now, you know, now we're going to be up kind of throughout the night dealing with a noisy machine. So we actually been given the okay to extend the treatment.
Great.
So this way we get that good 6 hours of sleep, you know, so we'll do up to 8 hours of treatment when the time permits, because sometimes, you know, like life, you know, we've got the kid, you know, we got to make sure she's good to go before, you know, the next day for school, make sure we're up 2 in the morning. So yeah, if time permits, we'll do it up to 8 hours of treatment, but sometimes, sometimes it's a 6, sometimes a 6.5 or a 7. So it just kind of depends on what we've got time to do.
You guys have a great story, and I'm sure that there are other care partners in the audience that would probably like to connect with you to share their stories as well. But we have one more speaker that I want to get to because he has a variety of experiences, and we want to make sure that we leave some additional time in case there are other questions. So Troyce, tell us about your experience.
Well, number one, Glenda, thank you so much for being our moderator. This has really been special. It's a good outfit. I also really want to tell everybody, all our participants that have come today, thank you. Thank you for taking your time to listening to this and hopefully getting something out of your life from the experience of all of these folks. It's not easy to take your time, to take your Sunday, especially off dialysis. So kudos to you all. My story is so long. We're just going to try this really short. I'm going to break it down into 10-year increments. Okay. So from starting dialysis when I was 21 years old in center, and then from 21 to 31, I did 2 years in center. I got a transplant and got 2 years out of it. I went back to home center for in center for 2 years, then to home chemo, and that kind of rounded me out to 10 years, my first experience with everything. I started as an educator when I was 27 because the National Kidney Foundation had a program called People Like Us. And it was the most fabulous thing in the world. Somebody from the office called and said, would you come talk about home dialysis? And I said, fabulous. And it was new patients. And I thought that was the coolest thing in the world because from the time I started, from when I was 10 years old until I was starting at 21, I had no experience. I mean, other than what my doctor said, and my doctor said, and at a child, son, we're gonna get you a little surgery in your arm and you're going to go on dialysis and hopefully we're going to get you a transplant. And I have plenty of people in college that are moving forward. And so, you know, that's what I figured out I was going to have. And things don't always go like you want, right? I built antibodies. So I had a much more difficult time to get a second transplant. I decided to go to peritoneal dialysis because it gave me the freedom that was just way above and beyond. And for all of you who are looking forward into a treatment, please look into peritoneal dialysis, talk to your nephrologist, and talk to some patients that have gone through this, because I got the most wonderful reprieve for 7 years on PD. And for those of you who want to travel, do not hold back. There's a lot of resources. I've done 100 presentations around the country. I've flown to 28 to big cities and a lot of short ones. And it can all be doable one way or another. In fact, I am going to Maui in December with my surrogate mother and her husband. They are treating me. And this will be the first thing I'll be able to do after the last couple of years. So that 20-year mark, things changed a little bit. more problems, heart disease. Eventually, I ended up with 2 heart valves having to be replaced. Open heart is a whole different ball game. I had 2 kidney transplants, and let me tell you, that was like playing ping pong compared to open heart. And I got a stroke as a bonus. They repaired my heart amazingly. I've not had a problem, but I did get a stroke, and I had to learn how to talk again. So I've I've gone into kidney kidney disease 3 times. I've learned to speak twice, and I have no idea what will happen in the future for me to have to challenge, and I'll do it.
You know what's really exciting about what you're saying, Troyce, is that most people don't go through the process of having strokes and having heart disease, as well as getting a transplant and being on dialysis. That is such a unique combination. I wish we had like an hour just to hear your whole story. But we're going to have to close down now to make sure that we have an opportunity for any people that have any questions that are remaining. And for any questions that we don't get to today, please feel free to send them to us. Patty will reach out to us and we'll get back to you with responses. So thank you very much to my panelists, and thank you to everyone who has joined us today. Back to you, Patty.
Thank you so much, Glenda. I am going to introduce our next speakers. It's now my pleasure to introduce Dr. Amro. Dr. Amro is a nephrologist at Swedish Medical, director of their PKD Center. Dr. Amro is a member of NKF's Regional Advisory Board and has led our team in both patient and professional education programs in the Pacific Northwest. We are grateful for his vision and expertise. Dr. Amro, please take it away.
Thanks very much, Patty, and thanks for everybody, Wilson, Doris, Julie, Alba, Troyce. It was very inspiring. It's my pleasure to introduce Dr. Suzanne Watnick. This is the Chief Medical Officer for Northwest Kidney Center. She is with wealth of experience and knowledge in managing kidney disease in different levels. She's gonna walk us through managing effect of kidney disease. And when I think about the effect of kidney disease, I usually think about effect related to kidney disease in general. That means effects that we encounter regardless of the etiology that led to the kidney disease and declined kidney function. This is the effects when we encounter when the kidney function declines, when the toxins accumulate. And there are occasionally effects associated specific to each disease, but the focus today will be the effect in general in any condition that lead to decline in kidney function. Dr. Watnick will leave the floor for you.
Dr. Amro, thank you so much. And everybody from the National Kidney Foundation in particular, I am so inspired by the stories that we're all hearing from the people with kidney disease who have been kind enough to join and tell their stories. So today, the first part of this next section, I'm going to focus primarily on one specific area, that of chronic pruritus or itch, actually, because it's something that, to be honest, in the last 5 years that I've been on faculty at the University of Washington, it's a topic we've never talked about. I gave a type of talk about this just a few days ago. Glenda gets to hear it again. But it's something that more than half of people on dialysis actually experience, and very few get a chance to have full relief. So I'm going to go through some of those slides relatively quickly, but we're also going to focus on a few other symptoms, including fatigue and shortness of breath from volume overload, and a little bit about gout. And those three in particular we'll focus on in the end when Dr. Amro and I have a little bit of back and forth. So with that, I'm going to do my best to start sharing the screen here. And if you'll give me the grace of just about 15 seconds, I will get this going and put this into presentation mode. Let's see. Okay. And can everybody see this now? I can't see people, so you'll have to let me know if this looks correct to everyone.
Not yet,
Not yet.
just seeing you, which is great, but
Okay, hold on a second. Let's try again.
If you try share screen, that will
I tried share screen, but let's try one more try. I'm sure a second time will be a charm.
looking promising. Yep, there you go.
Very good. Okay, we got this.
Promising. That is great. Let me get back into presentation mode. So we actually have a presentation and we'll dive right in. I have a feeling you're seeing 2 slides, but let me get into presenter mode. And my guess is this is working. Does that work for everybody?
Yeah, it's perfect.
Okay, great. So let me just dive right in. And, you know, I've been caring for people with kidney disease now going on multiple decades. I want to share for you the story of a person that I cared for about 6-7 years ago. This gentleman was a 70-year-old person on dialysis due to diabetes, who was a self-professed tough guy, a former Marine, who'd been on dialysis for a couple of years and had a pretty severe itch that was terrible at night. He couldn't tolerate dialysis. His wife said it was so bad that she couldn't sleep next to him at night. And he tried, just a number of creams and oils, but really hadn't talked to providers about this. He finally broke down one day and said, "Doc, this is driving me crazy. Is this common? Can't we do something about this?" So with that, I will tell you a little bit more about his story later, but briefly want to start talking about itch in people with advanced kidney disease on dialysis, what we also call uremic pruritus or CKD associated pruritus. It's incredibly common and distressing, under-recognized, and there are not a lot of treatment options. So let's just talk about itch to begin with before we go into dialysis related itch. People recognized that itch was a terrible thing, even back in the 14th century. In the Dante's Inferno poem, there were various circles of hell. And excuse my language, but in the almost last circle, circle 8, if you fell into that circle, you were punished by the burning rage of fierce itching that nothing could relieve. This wasn't actually medically defined until 1660 as an unpleasant sensation that provokes the desire to scratch. And people do believe that this evolved, the itching sensation, to protect us from the toxins from insects, because if you get an itch from that, you will scratch and move away the poison. People describe itches in all kinds of ways: solitary versus general, meaning all over; chronic versus acute, chronic being more than 6 weeks, which is what this type of itch is; contagious, meaning that you see somebody itching and you want to itch more; psychogenic, where you feel that there's something on your skin and it results in you itching even if it's not there; and the last of the types is uremic, which is the kidney disease or dialysis related. So let's talk about uremic pruritus. Uremic pruritus in particular is itching directly related to kidney disease without another reason, but oftentimes there are lots of reasons for it. It's usually on both sides, symmetrical, variable in intensity. You may or may not have skin lesions, but if you do, the acute lesions that you see are that of acute excoriations. You've been scratching and you can see bleeding, as you see in this picture. Hyperkeratotic nodules, which means basically raised nodules on the skin from the chronic scratching, and deep scars or nodules. There are actually studies out there that are not well advertised, but one person looked at all of the studies that had been done, and they found that there was a prevalence that was really pretty high. More than half of all people on dialysis experienced some degree of itch, even if it was just once a month, but related to dialysis, similar in men and women. And itching had strong associations with things such as an impairment in their quality of life, worse quality of sleep, So I hear, Alba's story. I wonder with the sleep issues, I hope that she's not having itching too. More severe depressive symptoms. So, can you treat some of these things and make the itch feel a little bit better? And there's even a study out there that had an association between worse itching and people who were hospitalized more or their survival was impaired. And if you look at the frequency of itch over time, there's a lot of info on the slide, but the bottom line is that over the years, different years in the 90s, the early 2000s, the 2000 teens, itching with dialysis has actually gotten less and less, but nonetheless, 2/3 of patients from the last time wave still experience some degree of itch, even if they called it somewhat. So, the prevalence is decreasing, but it remains underestimated. If you ask the medical directors in dialysis facilities, hey, what do you think about all the people that have itch in your facility? Most of them underestimate that, how frequently patients experience this. And, 1 in 6 patients with severe itch never reported it to anybody. Lots of people on dialysis don't receive treatment. So again, more than 1 in 6, with 18% with severe symptoms, use no treatment whatsoever. And there's a wide variation in the use of unlicensed, unapproved medications, but things that probably can help. So this is where I want to talk a little bit about different symptoms that you can have with end-stage kidney disease, but I do want to point out in particular, again, kind of small type here, but the second of all the symptoms in this long list in terms of how common it is itch. The most common is lack of energy, so that fatigue, which is one of the things we wanted to talk about today. So I do want to comment that, itching, along with all kinds of things, can make you very fatigued. Not having enough dialysis can impact on your energy. Making sure that you have the right treatment for your blood count, so your anemia, can impact your energy. And all of these things can ultimately impact itching as well. And I just want to look at some of these other symptoms in dialysis patients. Fatigue, so drowsiness. It's not just when you have machines alarming, for example, with nocturnal dialysis, you can be drowsy, but also just the fatigue of having your blood run through a pump multiple times a day. And thinking about all of that work that has to be done, for example, if you're on in-center hemodialysis, it's exhausting. Most dialysis patients will actually have substantial fatigue after their dialysis treatment in center. And even peritoneal dialysis patients, although it's a treatment that is very, consistent over the course of the days and the weeks, those patients, because they don't have adequate kidney function, can also be sleepy. Dyspnea or shortness of breath can happen very frequently. So you can see here in this list, almost 80% of dialysis patients experience shortness of breath. Now, why is that? Well, all kinds of reasons. Probably the number one is that you're not getting enough fluid off. And it is really hard if you don't have kidneys working 24/7, or your kidneys are only working 10% of the time, you can't get enough fluid off and you're going to get shortness of breath. But also the cardiac disease. You heard Troy's talking about the fact that 20 years in, he started to get cardiac disease. And 3/4 of all dialysis patients, when they start dialysis, have some effect on their heart, as evidenced by echocardiograms. So all of these things can impact shortness of breath. And you look at these other symptoms that I'm not going to spend as much time on: poor concentration, pain, loss of appetite. The swelling in arms and legs can also be a result of fluid overload. So how do you do that? Again, do you have enough dialysis going on? Is your kidney function still enough that you can be on diuretics, for example? So the shortness of breath and the swelling can be helped. But look at other things: dry mouth, constipation, nausea, all of the toxins that usually good kidney function can get rid of. Dialysis works to some degree like your kidneys, but it is not as effective as your kidneys, and it cannot get toxins out of your system to the same degree. So I'm going to continue on this itching journey. I hope people are feeling comfortable. And I want to talk about what's coming up. So the SONG initiative, Standardized Outcomes in Nephrology initiative, is this big international initiative to talk not just to researchers, not just to kidney doctors and kidney providers, but also to patients, which is critical to make sure we're thinking about a standard set of things to look at in trials for research in terms of outcomes. And they look at 3 different circles, the core outcomes that are critically important in all trials, a middle tier, which is important for some trials, and then an outer tier that's important to consider. And you can see that itching actually did show up as one of the things that the SONG group felt is important to think about for trials, to research, to get better treatments. And you can see here that it's, you know, all the way out there. Okay, maybe it's not all the way in the inner circle with fatigue, heart disease, vascular access. You heard Alba talking about her not being able to get a fistula, but needing a graft, and survival, mortality. But think about what itching impacts. So in these circles, itching impacts lots of other stuff in that 3rd outer tier, like anxiety and stress. Oh my gosh, if you have a terrible itch, you think that your anxiety is not going to be worse? Of course it is. It can make restless legs worse. It can really impact your sleep, just like Mr. J, who we talked about in the beginning of my presentation. Itching also impacts all kinds of stuff in that 2nd tier. You know, it is so critical to be able to get out and travel, get out and work. In fact, when you ask patients, one of the most important things that they worry about when they start dialysis is the ability to travel. And you heard, you know, Alba's and Anthony's story about how, you know, they used to be able to just get up and go, and they can't do that so much anymore. Itching impacts depression, you know, hospitalization, impacting patients, the family and friends, and itching and pain are very closely related. And of course, in that inner circle, that core outcome of fatigue, the more you're itching, it can really impact your overall ability to get up and have energy. So talking more about patients prioritizing symptoms, a really important piece of research that was published about 3 years ago, you know, looked at and ultimately prioritized 3 specific physical symptoms and 3 specific mood symptoms you see on the right: sleepiness, insomnia, the fatigue and cramps, along with mood, anxiety, depression, and frustration. But if you look at the identified symptoms, pruritus or itching was right up there, right with the insomnia and fatigue and the cramps. So patients really did identify this as something that substantially impacted them, that needs better treatment. So what do you think about when we think about reasons for having itch? And I'm going through this because then it helps us to identify what can we do? You know, how can we improve this? So we think about metabolic abnormalities in patients on dialysis. And what are those? Things like mineral and bone disease. So high phosphorus levels, high calcium levels, high parathyroid hormone levels, which impact both phosphorus and calcium. So those need to be treated. And just dialysis in general. If you don't have adequate dialysis, those toxins are going to build up and worsen all of those symptoms, not just itch, but also the fatigue, and also just the sensation of how you're breathing, for example, with that shortness of breath. And also other things like gout. If you're not dialyzed well, that's going to impact just any things that can affect you as a dialysis patient. Other antihistamines sometimes can be used for itch, but they're not very effective with this kind of itch related to dialysis and kidney disease. And dialysis patients in general have very dry skin. So really the first thing to think about is how to get that skin less dry. So creams, emollients, making sure with showers that you're using appropriate oils. And also toxins cause inflammation, which again impacts skin. And so things like UV phototherapy, which you can think about treating in conjunction with a really good dermatologist. You know, alterations in the sensory pathways can impact things. So a lot of dialysis patients have neuropathy, burning, tingling. And there's some success with the burning, tingling, itching with gabapentin medications, which I'll talk about in the next slide. And then lastly, I want to talk about opioid receptor dysfunction. And there are some medications that you can modulate that affect your opioid receptors that can not impact you like morphine would, but can impact those receptors that impact itch. So I do want to show a quick little figure about this opioid hypothesis. And so we all have opioid receptors in all kinds of places. It's the mu receptors that really are most associated with pain. And that's what we worry about in terms of addiction or euphoria, things that, oxycodone or morphine or other medications like that can impact, but there are also kappa opioid receptors. Stimulating those can actually help with pain relief and with itching. So we want something that can block the mu receptors or not impact them and get to the kappa receptors that might help. I mention this because it's always great to know about new medications, and I'll talk about that in just a little bit. The other thing I want to talk about are those receptors that can be hit, not just opioids, but also the pain pathways that have to do with sensory perception. So gabapentin or pregabalin, if you've heard of those medications, can help, but the studies that have shown that they help are really small samples of patients. They're not good methodology, but they do seem to show that they work. However, I do want to show you all that these medications can result in patients falling or having fractures or not thinking clearly. And that's the last thing we want for patients with kidney disease or on dialysis. So these might not be great medications to work. So the current off-label is ineffective, but there are some new agents that are becoming available. And I do want to talk about those a little bit on the next slide. But first, this is what we think of as of, really maybe 3-4 years ago, when you're thinking about that itch that so many dialysis patients have. Make sure you exclude other reasons for itch, like having an allergic reaction to a medication or a laundry detergent, for example. So make sure you talk to your provider, because if those are treatable, fantastic. But then you think about how severe it is. If it's not very severe, maybe think about moisturizing, oil baths, all kinds of supportive care, things that you can find over the counter, for example. If it's more moderate or severe, make sure that you're getting enough dialysis along with all the moisturizing, for example. And then you can think about that UV phototherapy or medications. We hate to add on medications. This was the state of the art really in 2015, 16, 17, even 18. But there is a new treatment option that is becoming available. Difelikefalin, which is a real mouthful, but this acts against those kappa opioid receptors that I showed you in that picture before. It doesn't go through into the brain, so it affects you on your skin, for example, but not across the blood-brain barrier to make you feel sleepy or affect your brain in ways that opioids might affect it. It also modulates the itch in kidney disease, and it's a medication that can be used at the end of hemodialysis, for example. It has been studied in a pretty good trial that was published last year in almost 400 dialysis patients. And they looked at an itch scale, and this is the result that they had. Patients got either placebo or this medicine, difelikefalin, and even the patients that got placebo and had attention paid to their itch had some improvement in the scale, but those that got the medication did even better. But I do want to let you know that only less than 1 in 20 dialysis patients even qualified for this medication. So I want you to understand it's not for everybody, but it is something new on the horizon for people with really severe itch. So it's nice to know that there's something out there. There were very few adverse events for this medication, but patients with this medication had more diarrhea, more dizziness, and more vomiting than if they got placebo. So again, you don't want to just take this without really being appropriate for your treatment. And it was evaluated in August to finally be approved by the FDA, which it was. It's not available yet, but it should be come January, February. I'm not going to go through all of these details here just because of time. But I personally have actually discussed this with Medicare, a Medicare group, to advocate for its use for patients who really need it. And so big questions remain. What kind of oversight do you need for this drug? Is it like, do you have to have oversight because it's an opioid? Or can we use it for patients with a little bit more laxity? And who's eligible to receive it? Is it all the people who've had a little bit of an itch, or really those people who have severe itch? And how's it going to be priced? We know some of these new medications are $2,000 to $3,000 a month. And, even if, for example, Medicare covers it and you have to pay for 20% of your medication, that becomes untenable. So we have to make sure and advocate that there's access for this drug for patients who really need it. So with that, I just want to let people know, and again, this is a busy slide, when you're on dialysis and you're covered by the payment system for Medicare, which 80% of all dialysis patients are covered for, there's a whole bunch of things that we think of that are covered by Medicare in terms of what is paid to your dialysis facility that you're entitled to. So you're entitled to managing your access and monitoring. So that means your fistula, your graft, making sure that you're given the right heparin. For example, you heard Alba talking about that. You're entitled to have coverage for your blood counts and making sure you're not anemic. So things like epoetin or Mircera or darbepoetin. So that may help with your fatigue. It also may help with your shortness of breath, talking about symptoms. And it also can help to make sure that your skin may be more intact, your bone mineral metabolism. We talked about that earlier, high phosphorus, high calcium, and then anti-nausea treatments, anti-infectives, meaning antibiotics when you have infections. Anti-itch medications are covered by this to some degree. So it's just good to know that it is very important and that Medicare does care and thinks about all these different functional categories. Also anxiolytics, if you get anxious, to what degree should things be covered during dialysis? And then we talked about that volume management. So when you get coverage for dialysis from Medicare, certain medications like furosemide, for example, to treat fluid excess or overload are covered by this. Also, dialysis is covered by this, of course, and it helps to get fluid off and helps with that volume overload and that shortness of breath, as well as some types of pain management. So I want to go back to the person that we talked about in the beginning, Mr. J. And so he was diagnosed ultimately with uremic pruritus by me and his new skin doctor. And there were some very specific emollients and creams that were prescribed. He ended up beginning some of the gabapentin medication, which helped a little bit. He ended up having higher doses because it had only helped a little bit. On higher doses, he had bad side effects. So he went back down to a lower dose. He started this UV phototherapy and he tried not to scratch his itch. But let me tell you, when you tell somebody not to scratch their itch, it makes it even harder sometimes. But ultimately, it did improve a little bit. Not as much as he'd like, but at least he could sleep through the night and get through dialysis. So by way of summary, what we talked about so far, and then we'll talk some more about some of the other symptoms. Itch, pruritus is common in dialysis patients. It's associated with not enough dialysis, dry skin, mineral and bone disorders, and those first-line treatments, the easy things, make sure you're getting good dialysis, control phosphorus, calcium, parathyroid hormone, give things for the dry skin, try to avoid scratching, and then think about other medications. If it's appropriate to give antihistamines, great. Pregabalin as well as the gabapentin, but watch out for side effects. If you need to treat anxiety or depression, think about the right medications for that. And then this new medication, difelikefalin, that's coming on may be helpful for those with the absolute most severe itches. And more than anything, one of the things that I know all of you out here, especially National Kidney Foundation, as well as I try to do on a regular basis, is not just to try to advocate locally for people with kidney disease, to get new ways to treat their diseases and innovative therapies, but to also work with the whole medical system to advocate on a national scene. So with that, I want to thank you for your time thus far. I know we're going to have more questions, and I'm going to stop sharing my screen as soon as I can. I'm going to pause sharing, and hopefully we are back to full screen. Are we back to full screen now?
Not quite yet.
Not quite yet. Let's try one more click. And how about...
Well,
There you
we're
go.
back.
Oh, wonderful. Okay.
Thanks very much. Thanks very much, Dr. Watnick. It was very excellent talk. And I'm going to try to funnel some of the questions that we received
Great.
throughout the talk. So from what I understand is uremic pruritus is a condition related to uremic toxins. So if patients does not have advanced kidney disease or patients not on dialysis, for example, patients with kidney transplant or early polycystic kidney disease, and they have pruritus, this is not consistent with uremic pruritus, although this is common. Is this correct?
With very advanced, so let's say you have a kidney transplant and it's failing and you're getting close to dialysis. That's a point in time where you might have this uremic pruritus. You're starting to have a buildup of uremic toxins, but you're correct. For somebody with an excellent functioning transplant, let's say with a kidney function of, even 60%, so not 100%, but even 60%, 50%, probably this is not the diagnosis for them. If they have itch, they should talk to people about it. And there's all kinds of things that can be looked into and treatments that can be used. But yeah, this is really for people primarily on dialysis. And maybe you could consider it for somebody with very advanced kidney disease who almost is at the point of needing dialysis, whether they have a kidney transplant or not. I also see a question about, does difelikefalin, this very brand new medication, help with peripheral neuropathies as well as itching? No, not felt. It may modulate some pain, but not traditional neuropathy.
And you like that a diagram, or you built a diagram in which how to approach the pruritus, in which you start with common things like emollients, skin care, followed by some over-the-counter medications, then possible gabapentin, and then moving forward. But I think the key took from today that if you don't tell your physicians, I'd like to know that you are itching. Is this correct?
That is so critical. I mean, it broke my heart to read the studies, to hear that 18% of patients on dialysis with severe itching were on no treatment, 17%, and also 17% had never said anything to their doctor. Care providers, doctors should be asking about that, but also please, as patients, bring it up if it's bothering you, because we want to help. There are things we can do. And in terms of what to use, really, thick creams and emollients, so something like Eucerin, for example, different kinds of, menthol containing medications, even oils that can be used post shower, for example, just to keep the skin from drying out, are really good choices. Things with no perfumes, nothing with additional additives. So as natural as possible is usually the best option to go.
That's great. And that takes us to the next issue, is lack of energy, which probably we are seeing for vast variety of kidney disease stages. So we can see this early on stage, as early as stage 3 kidney disease with lack of energy. Any take on this? And how can we identify this and mitigate the lack of energy associated with kidney disease?
That's so critical. So when you're talking about fatigue, lack of energy, there's so many things that go into it as a result of kidney disease. So first of all, it's important to address this and make sure to bring it up with someone to investigate it, whoever you may be seeking care with, your mid-level provider, your physician, because believe me, just because you have kidney disease doesn't mean that you can't have other kinds of fatigue. So first and foremost, you should work with your primary care doctor or your kidney doctor to say, are there other reasons for fatigue? Are you not getting a good night's sleep? And so sleep hygiene is critical. Are you in a quiet place? Do you have an environment that is conducive? So all of the things that we think about as primary care providers, first of all, just to address insomnia. Why are you having early wake? Are you waking up early at night? Or are you not getting to sleep? Because those can result in different kinds of treatments. And before you start going to any medications, you want to make sure, you're not eating at the very end of the day so that you have reflux, which causes problems and you can't sleep, for example, or you're on your screen and you can't fall asleep. And so that, so that insomnia is one of the biggest things in terms of energy, but there's lots of other things that are very specific to kidney disease. And so, there's a higher rate of insomnia, sleeplessness, in people with kidney disease. You saw it from the graph I showed, but other things can cause fatigue as well. So think about the things that your kidneys do. Your kidneys make erythropoietin. for example. And so if your kidneys are not making erythropoietin and your blood counts are very, very low, that can be a big problem. Or maybe you don't have enough absorption of iron because, you know, kidney disease can lead to poor absorption of iron, or you're not getting enough in the diet and you can't make enough red blood cells. So right there, that can cause fatigue. Also, if you're not getting enough oxygen to your brain. So again, making sure that you're getting, you have a reasonable blood count, but also that you don't have too much fluid in your lungs and you're breathing and getting that oxygen in. So it brings you back to enough, fluid overload, and making sure that your fluid status is okay, that you're not drinking, you're not eating too much salt. Even more important than drinking enough water, it's the salt that's going to keep all the fluid, which I think is a question you're going to ask me soon, but maybe we're covering it now, which is going to keep all the fluid in your blood vessels and your blood system, even more so than drinking water alone. So really cutting down on salt makes a huge difference. And so getting enough oxygen. So these are some of the things. And then also just making sure you're getting enough dialysis, because inadequate dialysis leads to fatigue. Cardiovascular health leads to fatigue. So making sure, along with your dialysis treatments, with all the other busy things you need to do and all the medications you have to take, more important is, making sure you're getting enough sleep and then getting some exercise. So anything that's heart healthy that you can do, if you're allowed to exercise, make sure you're doing that. And that actually, even though it can make you tired to exercise, ultimately it can give you energy on a regular basis. Anything else, Dr. Amro, that you wanted to add to that?
I think you hit a very important subject, insomnia, and a lot of our symptoms are related. I remember when I had a pulmonary embolism, I was hospitalized for 3 days, and I went into deconditioning. So the question of deconditioning, you have anxiety, you can't sleep, and you are very tired. You have to break this cycle. So you have to exercise to break the deconditioning, because deconditioning itself is one of the most common reasons for lack of energy. And I think the sleep hygiene you mentioned is extremely important. So have to screen when to stop looking at your screen in terms of iPhone and in terms of TV, and exercise. What's the best time of exercise? Early morning, early afternoon. Avoid something that rev your mind later on, because that's really, we got into the vicious cycle. You can't sleep, you're very tired in the morning, you can't exercise, so all these symptoms become very connected. So I think this is really important to look at the holistic way. How can we approach the kidney disease? Get enough manifestation, get enough dialysis, enough toxins removal. It is really important. Then break the cycle by exercising routinely, time the exercise, and avoid a stimulant early afternoon. And remember, a very question, and you can relate to that, is the first ask for a lot of patients is, what can we take medication-wise for sleep? Remember, the medication for sleep is the last resort. So we start with the sleep hygiene as the early on. And I think this is really important, how you look into this as an overall manifestation of the kidney diseases, manage them in a way that is holistic. Very good. Last thing I want to mention is, with toxins accumulation, occasionally uric acid will accumulate, that will precipitate gout. And for anybody who experiences gout, this is really unpleasant sensation. So placing a strategy in terms of diet, like Dr. Watnick, your diet is really important. So, you can't, all of us need to be restricted diet. When you have kidney disease, you have more reasons to be restricted. So dietary restriction is really important. And you have to have a strategy to manage the gout when it happens, and strategy to manage the gout to avoid it to happen. So I think this is equally important. And I think we covered all the questions that we had. Again, I think this is this as Dr. Watnick looked that as a holistic way. Look at how can we manage the manifestation of kidney disease in general by, first, adequate dialysis, second, speak up, and third, plan a strategy that gets you out of most of the symptoms or alleviate the symptoms. So that's really important. And thank you very much, Dr. Watt, for your time, and everybody. It's really a pleasure being with everybody today.
Great to be here. Thank you so much. I'm going to hand it back to Patty.
Thank you, Dr. Watnick. So thanks for that wonderful presentation, and for the questions we didn't get to, we'll include those answers in follow-up email, not just from this session, but previous sessions. And that email will be full of resources and information for you to utilize. Please take a minute to fill out the evaluation that's going to pop up when you close out, and tell us how we did. The added incentive is a $50 gift card, so give that a shot. We're so grateful that you joined us today to connect and learn and share. And I wish you all a pleasant evening and stay warm and dry. If your weather is anything like this in California, it's pouring. So thanks, everyone. Bye-bye.
See everybody. Bye-bye.